Our next session is on human-centric design in healthcare. And I am pleased to introduce you to Chris Waugh, the first Chief Innovation Officer of Sutter. As you heard, Sutter cares for more than 3 million lives, which is 1 in every 100 Americans. Chris Waugh applies his extensive human-centric design experience to making healthcare more usable and accessible for all. He's had a wealth of experience in leadership roles at IDEO, a globally known design and innovation firm, and was also the VP of Design at One Medical Group in San Francisco prior to taking this role. Chris is an influencer through his numerous TED Talks and many conversations across the country. And a fun fact, he's an Ironman New Zealand finisher. In conversation with Chris is Mohan Giridharadas, founder of LeanTaaS. LeanTaaS is a predictive analytics company that uses AI and machine learning to help hospitals unleash the capacity of their resources and optimize their investments. LeanTaaS has hundreds of installations in hospitals across the country. And prior to this, Mohan was a senior partner for 18 years at McKinsey. He ran many global practices. He's a humorous storyteller and the author of the book, Better Healthcare Through Math. Over to you, Mohan.
Thank you, Anita. Chris, good to be with you. Let's kick it off with just defining human-centered design. When you think about human-centered design, what comes to your mind, Chris?
Yeah. First, Mohan, just want to. It wouldn't be very human of me to not recognize all the mothers out there. So just wanted to say that first, and for the folks that have given up some of their Saturday to listen to us, and I hope that's well worth their while. I think human-centered design is vastly misunderstood because it's more disciplined than people realize. And Mohan, it's exciting to talk to you today because your angle on math and data complements and is really the ultimate blend of human-centered design plus that math. But human-centered design starts by understanding constraints, going deep and understanding empathically what's really going on in people's lives, not just looking at the data, but clicking deeper than that into what's really happening for them, getting very creative with solutions, so going very unconstrained, and then bringing that back into a controlled trial where we can iterate and evolve and ultimately scale the solution. So it typically also flies industry agnostic. So our team doesn't care if the ideas are coming from healthcare, if they're coming from retail, if they're coming from tech. It doesn't matter. It will look far and wide for inspiration to address some major challenges. And it doesn't assume because healthcare has tried something before that it's not worth trying again. It's often about right time, right things, right people, and right elements. And COVID really demonstrated to us in real time what it meant to do similar things in a new environment. And there was a number of breakthroughs.
Great. That's a very expansive definition of it. When I think about human-centered design, I want to take all of the humans involved. It's very easy to get locked in on the patient experience, but the patient experience is delivered by the providers, by the staff, by all of the support services that are involved. And so somehow designing the healthcare delivery system that touches and impacts in a positive way everyone who's adjacent to it. So with that in mind, Chris, one of the emerging forces at work is the consumerization of healthcare, which we're seeing happen in every other industry, and it's starting to be very prevalent in healthcare as well. When you think about consumerization, what comes to mind for you?
When I think about consumerization, I think about really what underneath all of this is what are people craving, right? How do they want to receive care? And in their minds, healthcare is not that different from other services. So why can't I have it the way other services work? And I think that's a very fair assumption on their part. I think consumerization for us from an industry perspective out looks like pretty significant shifts from what was happening to a hospital, to ambulatory, to the home, and now everywhere. So the human body goes everywhere, and we're seeing an emerging world where there's a tether to what's happening more often and more frequently, back to an understanding of what might be happening in someone's life, and maybe less waiting for symptoms, for example. So a lot of consumerization is about convenience, and as the industry would put it, data, right? It's like, what's really going on? But for us, that data is about more life understanding and more empathy with the context that someone might be in. And I'm curious to hear your answer as well, as I think you make a great point around, there are many humans in that chain. And if you get it wrong for one, you get it wrong for everyone. So if you do the perfect consumer design for a physician, you might have overlooked the fact that you put all the burden on the physician. So really, the design is complex, but our through line is the end person. And then who are the people in that stakeholder chain that you need to design for along the way. But curious from a LeanTaaS perspective, how you think about consumerization.
For us, it was very interesting to watch consumerization, as in a very simple example. COVID created an accelerant that health systems weren't prepared to think about. So one of the health system executives we'd worked with said that telehealth had been on the design table for 5 years, and they'd made lots of progress, but in slow and measured terms. When the pandemic started, less than 1% of their visits were happening over a telehealth platform. 4 weeks later, 60% of their visits were happening on a telehealth platform. So for years, they had been talking about migrating to telehealth, and then they just suddenly did it because they had to. Patients didn't want to come into the clinic. It was difficult. It was dangerous to have patients next to each other in a waiting room. And so the pressure to go to telehealth rapidly was there. Luckily, the groundwork had been set. So the platforms and the infrastructure, et cetera, were moving slowly. It was just the belief that it could be done. There were oncologists who did not think that it was possible to do their kinds of appointments on telehealth. And suddenly they were doing 60% of it. Now it's stabilized from what I see at the 20-25% of appointments are on telehealth, but it's broken the back of the myth that it cannot be done. Right. Yeah. And so that was a very interesting thing. If you
build on that really quickly, is to add human-centered design to that is, yes, you can do what you were doing, delivery of care done virtually, but what fascinated us is to watch how consumers, the theme we're on now, behave or respond to that. So things that really inspired us were consumers that said, hey, I want to invite my sister from Portland and my spouse who happens to be in another city right now to this same medical visit. And really, all of a sudden, it was a whole family visit. Impossible to do in person, but virtual let it happen. So what I know you and I agree on this is really an opportunity, one, to deliver the existing care virtually, but also with these new set of tools, you can reimagine the way the care is delivered. You couldn't do multiple city visits before, and now you can. So what does that mean? There's a fundamentally deliver of care rethink going on there. So sorry to cut you off there, Mohan, but I think that's where human-centered design plus telehealth start to intersect.
That's a fascinating metaphor, to put multiple people into the same visit. The early days of television, they were still adapting to the shift from radio. So television anchors would read the news out on a piece of paper versus taking you to live shots. And so what you're talking about is fully leveraging the possibilities of the platform instead of simply replicating a physical event over a virtual platform. Correct. When you think about applying this consumerization to the concept of waiting time, because patients wait and that's a source of frustration, how do you think about how consumerization could help attack that problem?
Yeah, so it can be irritating for human-centered designers to constantly ask the why, right? So the first question is to step back and ask why are they waiting and what are they waiting for? And this for us, the human-centered design is what guides technology, right? We hear about AI, we hear about digitization, but really, what's its true north? What's it serving? And when we ask why are people waiting, a lot of times what they're after is they want to know what's going on with them, and they want to know what the next step is. So we hear a lot about machine learning. We partnered with a company called Ada And through Ada, we could do symptom checking, and it's answering the patient question, which is what's going on with me. And then the next part is, let's make sure that an appointment is the right next step. Now, before, that's not what was happening. It was the patient has a request, and therefore we'll try to find the next available slot for them. Now the reframe is, let's give them insight as to what might be going on and what the next course of action might be, better guiding them to where they need to be, which helps better load balance the system to make sure the right patient's going to the right place. And we know it works because 500 patients a day are using that tool. And that's a service and a feature that just didn't exist before. And the machine gets smarter every day. So, you can continue to iterate that forward.
Mm-hmm. The wait time is near and dear to our hearts. We spend all of our energy on optimization of both the schedule and the allocation of assets, because here's an interesting thing we discovered. Patient satisfaction is driven largely by the quality of the clinical outcome. So superb clinical care leading to good clinical outcomes will lead to patient satisfaction. The flip side of that is patient dissatisfaction is largely driven by wait time. So what patients will do is, even if they got a great outcome, they're happy about that, but they're unhappy about the wait time. Their tolerance for the wait is directly proportional to how unique the caregiver is. If they've got a rare cancer and there's only one person in the world who can solve it, they will put up with a lot of wait time because they know this is the only person in the world who can save them. But if it's a more routine clinical appointment, they're more likely to switch providers and even switch out of systems. So wait time matters. What we've found is health systems haven't fully grasped the complexity of wait time because it's a nonlinear function. It's very tightly tied to utilization. It's very tightly tied to how supplies and demands signals are balanced. And therefore, wherever you go, you see this rush hour effect. Early morning, the labs are backed up. Middle of the day, the infusion therapy is backed up. Late morning, there's a backup on trying to get a patient into a bed. Late afternoon, there's a backup trying to get patients discharged. It's the wait time conundrum that health systems are just starting to grapple with. Chris, from your vantage point at Sutter, our perspective is that EHRs are not built to solve this problem. It's a hard problem for EHRs to tackle. I'm curious as to your thoughts on that.
Yeah, I think the EHR can't do it all, and I think that's often misunderstood. That the idea that a single software would do everything we need it to do, it's just way too much pressure for a piece of software. Sure, that would be convenient, but the EHR is tremendously valuable. Obviously, everything's gathered there, and there's a tremendous amount of data coming off of that. But it's the things that connect to that EHR, obviously thinking about that from a safety perspective, and it's got to be rock solid in security. But there are elements that you need to combine with that EHR to make it more useful, and the information that's going in and out of that EHR. Excited about opportunities for better understanding. What we think a lot about, for example, are underserved populations, and we can use the EHR to guide us to extremely vulnerable populations. But what really excites me, and I know you and others, is once we can start to combine more and more data sets to grab more understanding of what's happening, ideally with the person's knowledge that is exactly what's happening, that's going to be very interesting, because that combination of understand elements, whether that's information I use often. We've suffered a lot of fires in Northern California, and if we could simply combine weather data with EHR data, we could proactively send inhaler refills to asthmatic patients when we know smoke is headed towards their house. So that's the kind of thing you can do in the combinations. But I agree with you, the EHR can't do everything. It's an extremely valuable tool, but I agree with you that other elements need to combine with that tool.
Right. What we found is it's done a remarkable job of being the single source of truth, where every encounter, every appointment, every lab result, every provider, every patient is captured in one place, which gives you that. The idea of attaching weather data is a very clever one, because it now gets into population areas. The reason we find the limitation of what the EHR can do is deep down, they made a very simplifying assumption that sounds logical. that an appointment is a reservation on a resource. So when I have an imaging appointment 8 to 9, it's as if I reserved machine number 1, 8 to 9. That works great if you're reserving conference rooms or tennis courts, because those are predictable start and end times locked down. When you're booking medical appointments, there's too much uncertainty around it. So this model of trying to do scheduling like a static thing is where it breaks down. And that's where we're finding layering the EHR data with adaptive machine learning, adaptive templates, artificial intelligence can help the health system use it much better. Let's switch gears, Chris, and start talking about the provider. When you think about that aspect, the provider, for how we think about human-centered design, what comes to mind for you?
Yeah, for us, providers are critical to the delivery of care, and their own health and well-being is extremely important so that they can function as effectively as anyone in a very demanding role. So, for example, here is when COVID started, this is an example of human-centered design coming to life. We knew that certain medical staff were exposed to COVID, and remember at this time, a lot was unknown. We knew that we needed to quarantine exposures for 14 days. And we knew that those folks probably didn't want to be very far from their families. So the other thing that was going on for them is, turns out providers have kids too, right? And how could we look empathically at their lives, not just their clinical life, and understand that perhaps the best thing we can do is subsidize childcare, which is one thing we did very early on in COVID. And the other thing we did was, which is unusual and expresses human-centered design, some of which worked and some didn't, was team up with Airbnb and a small startup called Outdoorsy. And we could connect people's proximity to home as close as possible, and even deliver the equivalent of like an Airstream to their driveway if they wanted to quarantine and not leave the house. That's just, not many people took us up on that offer, but you can see us like pushing what's possible here. And maybe that's not as unusual as we think. And certainly there's a communications element to that and whatnot. But provider health and well-being is critical to continue to deliver this care, and really having compassion for things like, is every case the hardest case for every provider? Back to your point on scheduling, is do you schedule extremely hard cases every hour of every day? Really having compassion for what's the best way to, like any of us would want to, when our providers at their best, what's the best opportunity for them to engage some really difficult cases, et cetera. So just having a lot of human-centered compassion for their lives too.
Mm-hmm. What we found in our work is lots of the burden that falls on them goes unnoticed on providers, or both the physicians as well as the nurses. So for instance, infusion nurses miss their lunch break a lot. There are some health systems where 80% of the days they miss their lunch break. Why? Because the peak is at lunchtime, and infusion nurses are both patient-centric and safety conscious. They get very nervous that they've just started the flow of really complex medications into someone's body. Walking away to get a sandwich at that point doesn't feel like a great thing to do. So they skip their lunch and they hang out. Meanwhile, providers get so overworked because their templates are so jammed that they end up sitting up late at night writing, catching up on their notes, entering it back into the EHRs. One health system used to call it pajama time. They used to actually measure the times that a physician had logged into the system to enter notes after 9 p.m. or 10 p.m. at night. And so we started to study this template. You talked about a new, really complex case every hour on the hour. So we started to study the templates, and it turned out to be very interesting. Providers are wildly different from each other because they've been trained over a 30-year period to see patients in a certain way. And so whenever the administration tries to simplify templates, standardize templates, and tell them how to stack their day, it just doesn't work because each provider has built up a really complex choreography as to how they send the nurse in, send the tech in, they go in, etc. But what is remarkable is providers are very consistent with themselves. And the metaphor that comes to mind is if you watch Roger Federer play a tennis match, from the very first serve of the very first set to the last serve of the last set, he's got the same service routine. He'll bounce the ball the same number of times. He'll look up at exactly the right time, and he'll serve in the same way. And so providers are a bit like that. They'll always see a new patient in the same way. So human-centered design to us is, rather than jamming the provider into accepting a template that you push down his or her throat, it's how can you adapt the template to fit the style of the provider, because that's been built. So we call it a fingerprint, and we try and turn that problem on its head.
Yeah, you're making a great case for what we believe in wholeheartedly, which is co-design, right? So my closest colleague, Dr. Albert Chan, is a practicing physician and helps run our digital health. He leads our digital health efforts. And Yumi Dianji is a close friend and colleague. She leads a new model, Dr. Yumi leads a new model of primary care. And her feedback is as valuable as anyone in infuse.
So Chris, you were talking about adapting the provider templates.
Yeah, of course, we need one tech miss in the event. But yes, co-design. So we've done this recently with mental health. So philanthropy funding, 2 mothers, their children had really poor, significant depression, anxiety issues. Teamed up with them to rethink youth and adolescent mental health care. So you involve our providers, the youth themselves, the parents, and you design something that's really different. Fast Company picked that up this week in a world-changing idea of a app experience created for youth and adolescent mental health. And it looks really different. It feels really different because it was co-designed with them. And you're making a great case for provider co-design. You can't do it in a silo. You've got to do it collaboratively. And I couldn't agree with you more. Now you have to also infuse what's possible. That's what's happening on the tech side is, did you know it's possible to deliver care in multiple countries at the same time? A provider may not realize that, or watching technologies like Elon Musk and what's going to happen with satellite-based Wi-Fi. That could really help our communities that don't have reliable access to Wi-Fi. So we know that's coming. So the innovation team's job is to make sure we're aware of that and that the cost will come down, and then infuse that with providers thinking to say, now what could we do with a different constraint set?
Chris, in your role with innovation, you must have to think through the build, buy, partner with all of the various entities you come across. How do you think about that, and how do you guide making the right trade-off?
We think about the population we're serving, of course. Our mission overall, is this going to advance what we're trying to do? We definitely think about speed. What's going to be the fastest way to go? So building your own is going to be slower. Sometimes there's a good reason to do it, but speed is of the essence. And of course, we think about safety and security for our patients. And so those elements are critical. And as we've seen in COVID, it's about speeding up. So we've been extremely pressed with how many are we able to pivot so quickly, like Zoom and others. And then how do we make sure we're staying in tune with quick changes as well as partnership changes, because someone may not have been HIPAA compliant 6 months ago and they are today. So you've always got to be listening and who's going to be the fastest partner and the best partner, or should you do it yourself because the context and the problem is so unique.
Right. We see that a lot as well. There are some problems where the health system is uniquely positioned to build it because they've got some distinctive unique expertise or unique access to data or just the right petri dish in which to experiment. There are other cases where we believe health systems underestimate the difficulty of moving from a one-off data model that's proven impact to a scalable, supportable thing. Because even the simplest application takes tens of millions of dollars and hundreds of people to support on an ongoing basis once you have hundreds and thousands of users. So there's a good reason that JP Morgan Chase doesn't build its own spreadsheet, even though it's got 10,000 engineers and a $20 billion IT budget. It just says Microsoft has spent a lot of time and energy supporting it. We should just pay $200 and buy a copy of Excel. So this notion of really understanding what it takes to build versus just jumping into it feet first is one thing that we find a lot.
Yeah, that's very savvy. And yeah, just knowing what are you've been through all the enlightened trial and error and the pain points and the regulation, to get things sorted and get it right. And just making sure that pipes effectively to the system. And I know LeanTaaS has thought a lot about that is we see a lot of solutions that have no connectivity to the main ecosystem, and that's just a non-starter. So yeah, appreciate you and your work and how you think about this. And I've really enjoyed this conversation with you.
Thank you, Chris. I enjoyed chatting with you. I think we're right on time for this session. So I'll turn it over to the moderators.
Thank you, Chris and Mohan.